and this is Authentic Parenting, a podcast about growing ourselves while raising our children. I'm a psychologist, educator, and parent coach, and on this podcast, I explore how you can connect to your authentic self, practice radical self-care, and raise emotionally healthy children. Let's break the generational cycle of trauma for a more peaceful, kind, and compassionate world. Today, the benefits of cognitive behavioral therapy. There are numerous approaches to psychotherapy, bottom-up, body-based somatic modalities such as SE, somatic experiencing, developed by Peter Levine, and top-down approaches such as talk therapy. The terms top-down and bottom-up refer to the general area of the brain and where you start in therapy, bottom referring to the brainstem and top referring to the prefrontal cortex. One is not better than the other. They're both valuable and they both have strengths and limitations. In fact, people may benefit from a mix of both approaches. When it comes to trauma treatment, my preference is bottom-up modalities. I do think they are more effective, and perhaps that's the reason that almost exclusively I have given more airtime to such approaches. My goal, however, is to explore various therapeutic approaches here on the podcast to give you a better understanding so that you can make an informed decision. We have an episode on IFS, Internal Family Systems, with Dr. Dick Schwartz. Earlier in the year, I dedicated 2 full episodes to talking about a form of therapy called EMDR. We have several episodes on nervous system regulation and so on and so forth. And today, I want to share an episode about the top-down therapy called Cognitive Behavioral Therapy, CBT. My special guest for this episode is Dr. Melissa Hunt. She is a licensed clinical psychologist and serves as the Associate Director of Clinical Training in the Department of Psychology at the University of Pennsylvania. I found several of her papers that piqued my interest and curiosity. She is a fellow and diplomat of the Academy of Cognitive Therapy, a member of the Rome Foundation Psychogastroenterology Working Group, and a member of the Pennsylvania Psychological Association Ethics Committee. On the academic side, she conducts research on the best approaches to stress management and into the causes and treatment of depression, anxiety disorders, and chronic GI disorders. In addition to her research and teaching, she maintains an active private practice in clinical psychology. Dr. Hunt is the author of 2 evidence-based, empirically supported self-help books that make CBT accessible to patients with IBS and IBDs, and has collaborated on developing an app that provides CBT for IBS. She has also published numerous research papers, including a number of randomized controlled trials testing the efficacy of self-help treatments for patients with GI disorders. She also has 2 affectionate golden retrievers, one of whom often works with her as a co-therapist and research assistant, a cat, a snake for treating phobias, and numerous goldfish. In this episode, she provided an overview of cognitive behavioral therapy, discussed what CBT can help with, debunked some misconceptions about CBT, and explained the benefits of cognitive behavioral therapy. As I mentioned, I read several of her papers, and I was really interested in exploring the topics of her research, but I was able to discuss only one of them on mindful breathing versus diaphragmatic breathing. I really enjoyed talking to Dr. Hunt, and I hope you will find this episode helpful. But before we get to today's episode, let me share an important note. Since 2015, I have poured my heart and soul into creating and producing this podcast. It holds a special place in my life as it allows me to deliver high-quality content that truly matters without relying on paid advertising. Just as I live my life guided by values such as generosity, contribution, community, service, integrity, this podcast embodies those principles as well. I am committed to maintaining the podcast's independence and ensuring that it remains a platform dedicated to your growth and well-being without paid advertising. That's why I am wholeheartedly seeking your support as a listener. I believe in the power of community, and I want this podcast to be fully listener-supported. There is a tremendous amount of work that goes into delivering high-quality content to you, from the initial planning to conducting interviews, editing, and promoting each episode. It's a labor of love that requires time, effort, and financial resources. Additionally, there are hosting fees to keep the podcast accessible to you. However, despite the challenges, I am deeply passionate about creating this podcast. It enriches my life beyond words, and with your kind support, I can continue bringing you empowering content on a weekly basis without interruption. By relying on generous donations from our listeners, we can uphold the integrity and authenticity of the show. It allows us to remain true to our mission, providing you with valuable insights and life-changing conversations without compromising on the quality and diluting the content with intrusive advertisements. If you have found value in our podcast and witnessed its positive impact, I kindly invite you to consider making a donation. Your donation, no matter the size, will make a significant difference. Together, let's ensure that this podcast continues to thrive and touch the lives of individuals and families around the globe. Thank you for considering supporting this meaningful endeavor that means so much to me. Your generosity reflects the spirit of our community and reinforces our commitment to authenticity and growth. To contribute and learn more about how you can help sustain the show, please visit authenticparenting.com/support. Once again, authenticparenting.com/support. Let's embrace the power of listener support and make this podcast a fully listener-supported show. Thank you for being a part of our Authentic Parenting community. Your support and presence are deeply appreciated. Together, we can create a more peaceful, kind, and compassionate world. Please enjoy. Melissa, welcome to the podcast. I am delighted to have you on today.
Thank you so much. I'm delighted to be here.
I'm really interested in all of your work. I think a good place for us to begin would be cognitive behavioral therapy, since much of your work falls under cognitive behavioral therapy. I have read some of your papers and I'm really interested in exploring some of the ideas today, but I don't think we've covered cognitive behavioral therapy on the podcast. So this is the first time. I think it would be a great place to give an overview, what it is, what it's good for, and then we'll go from there.
Oh, I'm so glad to have the opportunity to do this because I think cognitive behavioral therapy sometimes gets a bad rap out in the public consciousness. It's seen as a little bit too superficial or too mechanistic, or it's just a collection of techniques. But that's really a mischaracterization or a misunderstanding of cognitive behavioral therapy. Cognitive behavioral therapy is an entire system of psychotherapy, which means it's based on some really core understanding about how people learn, how people behave, how people try to cope, how people respond to things, how people manage fear and sadness and all kinds of things. And because it's very much based in a scientific understanding of how people learn and behave and cope and feel. And because the therapies themselves are derived directly from that understanding and are then tested in multiple clinical trials to prove that they work, there's a reason that cognitive behavioral therapy is, generally speaking, the most empirically supported evidence-based treatment for lots and lots and lots of different problems, including depression and anxiety disorders like panic and social anxiety, including trauma-based disorders like PTSD, including chronic complex PTSD, including GI disorders and various kinds of health-related problems, sleep problems, and insomnia. Cognitive behavioral therapy is generally going to be the first line, most effective treatment for most of these things. So what is cognitive behavioral therapy based on? Well, it's based on a couple of things. Number one, it's based on the idea that what we believe about things matters a lot in how we feel about them and how we react to them. And beliefs can be accurate or inaccurate. And if we hold inaccurate beliefs about things, like, for example, say that all golden retrievers are terribly dangerous and could attack us and hurt us and rip our throats out, then that's going to lead to a lot of fear every time you see cute Rusty the golden retriever with the red bandana at the park. And it's going to lead to a lot of maladaptive behavior in an effort to keep oneself safe, right? So one is going to experience a huge jolt of adrenaline and fear, and one is going to run away and leave the park if at all possible, and certainly avoid contact with the dog. But of course, that fear and that what we call maladaptive avoidance is all based on a faulty belief that all dogs are dangerous and can harm us, right? So what we do is we get people to identify the underlying beliefs that they have that may not be very helpful. And then we get them to act differently, to do behavioral experiments, to do exposure therapy. So with a terribly dog-phobic person, I would actually go out with them to the park and we would find random dogs to approach and we would ask people, hey, can we come pet your dog? Or I would bring my own dog into the office and we would start there. And the person would slowly learn and be brave and approach the dog and would then learn that, oh, not all dogs are dangerous. And these thoughts and images and things that I was imagining in my head actually don't come to pass. Now, treating a specific phobia like a fear of dogs or a fear of snakes, that's kind of the most obvious, simple approach. But we can apply this exact same approach to lots and lots and lots of different scenarios. It can help with anger management. It can help with substance use disorders. Cognitive behavioral therapy is an incredibly powerful approach to lots of different things, and it's been proved to work over and over and over again. And it's also worth pointing out that for some disorders, like, for example, obsessive compulsive disorder, which is not just hand washing. Lots of people think, oh, I know what that is. It's just hand washing. It's not that. OCD is a whole brain disorder that can affect lots and lots of different kinds of symptom clusters. People can have terrifying, intrusive thoughts. They can engage in compulsive rituals that take hours and are really distressing and disturbing to them. Cognitive behavioral therapy, a specific form of it called exposure and response prevention, is actually the only effective treatment for OCD other than medication. So CBT is really powerful, and it's really exciting for me to be in a field where I've been able to adapt and expand some core CBT principles to new disorders like chronic GI disorders, including irritable bowel syndrome.
Let's take the fear example first. And obviously treatment, therapy depends on the person. Obviously there is no set number of sessions that someone can overcome their fear or anything like that. But do the symptoms reoccur after a successful CBT therapy round? Do the symptoms of like the phobias come back? What's the likelihood?
That's a fantastic question. And the answer is twofold. Number one, the first answer is it depends. It depends on the nature of the disorder. So in lots of cases, we can do a relatively short round of CBT and it solves it. Like the person is no longer distressed and it does not come back. Those symptoms do not reemerge. In other disorders that are more chronic or relapsing remitting disorders, which could include depression or obsessive compulsive disorder, or sometimes even social anxiety disorder, what we will see is that the symptoms may bubble up again, especially in times of stress or duress, if the person is very tired or very overwhelmed. But the wonderful thing about CBT is that you've taught people skills that they keep for a lifetime. So, for example, when I've worked with a patient with obsessive compulsive disorder and we've done a lot of exposure therapy and the person has been super brave and confronted all these things and agreed to sort of keep themselves from doing the ritualized compulsions that they normally do, and they've sat through it, and the distress has really come down and they don't feel the same compulsion anymore. And they're doing great, and we wrap up and we terminate and we high five each other and we say, well done. It may well be that a year later, that person will have a change of life of some kind. They'll change jobs, or maybe their first child will be born and the OCD will bubble up again. It's a genetically based brain disorder. And sometimes the person will even call me up and say, hey, Dr. H, started really obsessing about fire retardants in my baby's mattress. And my wife finally looked at me and said, I think this may be OCD. Maybe you should call Dr. Hunt again. And they'll come in and we'll do 1 or 2 little booster sessions and then they'll be good to go. Sometimes they don't even need to come in to see me because they have the skills to know, oh, I'm feeling kind of panicky right now. Okay, I know what that is. That's a panic attack. I just need to take a few deep diaphragmatic breaths. I need to not freak out. I need to not catastrophize this. I'm not dying of a heart attack. I don't need to go to the ER. I know what this is. I'm fine. And because they have that knowledge and they have those skills, they don't even need to come in to see me again. They can manage whatever little blips of the disorder come up for them because they have the skills. And that's one of the things that I find so compelling and wonderful about cognitive behavioral therapy. It's fundamentally respectful. It's collaborative, and it teaches the patient the skills that they need to manage things more effectively moving forward. My job is always to do myself out of a job. I tell patients that all the time. I said, we will know that we're done when you come in for a session and we sit and we chat and we catch up, and it's lovely. And I really enjoy hearing about what's going on in your life. And at the end of the session, I look at you and I say, did we do any work today? Or were we just visiting? Were we just chatting? And the patient smiles and says, yeah, I think we were just chatting. And I said, good, you're done. You've graduated. You don't need me anymore. And that's always a great day at the office.
So the beliefs, are these beliefs formed in childhood or it doesn't matter? I'm wondering if the beliefs that are formed early on are sort of hardwired and harder to break those beliefs as opposed to things that occur later in life. Let's say, I was not scared of dogs and, at age 40 something, I had an incident and I got scared of dogs and now I'm afraid of all dogs, as opposed to something that is, rooted in my childhood. Is there a difference in those beliefs?
So that is also a fantastic question. You're asking me great questions here today. And the answer is yes. And so absolutely, there's a difference between people who might have some one-off experience in adulthood. So for example, someone who's always been absolutely perfectly healthy, athletic, married, kids, really happy, part of a men's softball league, sees themselves as super athletic, gets a really random wasp sting or something that they have a horrible allergic reaction to, and maybe it gets a little bit infected, and the whole thing is just really scary, right? And suddenly this person may realize, oh my gosh, I'm fragile. I'm vulnerable. I could die. This is terrifying. And then they will have what we call a de novo panic disorder, that all of a sudden out of the blue, even though they've never been particularly anxious, they've always seen themselves as very resilient and healthy and brave and strong and all these things. they'll suddenly start worrying about every little, oh my God, I stood up too fast and I got really dizzy. What if I have a brain tumor? Oh no. And then they start getting very panicky, or they'll notice a little thump in their heart and they'll think, oh my gosh, well, I'm a guy and I'm in my late 30s. What if I actually have some kind of weird underlying heart disease thing that I didn't know about and I could just drop dead of a heart attack? And as soon as you have that thought is very frightening. Well, what happens when we get afraid? Our breathing gets shorter and more shallow and faster, and our heart speeds up and our blood pressure goes up and our muscle tension increases throughout the body. And before you know it, that person is actually experiencing chest pain and their hands are tingling because they're actually hyperventilating. And now they think, oh my goodness, look at this. I really am having a heart attack. I'm having chest pain and my hand is going numb. And before you know it, they're off to the ER. And at the ER, they hook them up to an EKG and they check their cardiac enzymes. And the doctor says, your heart's fine. Here's a Xanax. Go home. Talk to your primary care doctor tomorrow. Right? And then they don't know what to think because they really believe they were having a heart attack. So now what I do is I bring the person in and we, explore all of this and we say, okay, you're having a lot of catastrophic cognitions. Understandably, you had a really scary health crisis, right, with that bug sting. But now you're just catastrophizing things that are completely normal. And again, I'm going to teach that person deep diaphragmatic breathing. They're going to learn how to slow down all of that sympathetic reactivity. But then we're also in session going to actually intentionally hyperventilate, for example, or breathe through a straw or spin around really fast to get dizzy. And we're going to sit there and we're going to experience those sensations. I do it with them. And we're going to say, see, this isn't dangerous. We're fine. And then we switch to deep diaphragmatic breathing and we get everything calmed down. So that's an example of someone who is an adult, might have a one-off thing. And honestly, I love working with folks like that because it often only takes 4 or 5 sessions, maybe sometimes as little as 3. And they're like, oh, I'm not having a heart attack. No, you're not having a heart attack. Okay, I'm good. Now, in contrast, if I'm working with someone who had a much more complex childhood. So, for example, someone who was mistreated. Maybe they were in an emotionally abusive childhood. Maybe it was even worse than that. Maybe there was actually neglect or physical abuse or sexual molestation by, a cousin or a babysitter or something like that. Let's say that person grew up feeling like the world was not a safe place, that they could not count on people to take care of them. Maybe there was an alcoholic parent who was very depressed and very checked out, or very angry and very unpredictable. That's someone who's grown up believing, quite understandably, that the world is not a safe place and that maybe that they're not really worthy of love or of being taken care of. That person might, as an adult, have chronic complex PTSD from childhood. They might have terrible depression and what we would call a core self-schema, that they view themselves as kind of defective and unlovable, right? Because where do we get the messages that we're lovable and worthy? Well, the very first people we get those messages from is our parents. So if you have a parent who's an alcoholic and is angry and abusive and unpredictable, or you have a parent who's horribly depressed and checked out and just lies on the couch and doesn't ever make you dinner or help you with your homework or even wash your clothes, you're getting a message over and over as a child that you're not really worth taking care of and that the world is not a loving and safe and benign place. So I love working with those folks too, but it takes a lot longer. With those folks, we are going to go back and we're going to look pretty carefully at childhood history. We might really do some exposure therapy and what we call imaginal restructuring, where we go back and we look at some of those childhood memories and we'll re-script them so that we'll actually imagine, for example, that their adult self could enter into the room to protect their child self from the abusive alcoholic father's beating. So we're not creating false memories here. No one's going to actually believe that their adult self was there when they were 8, right? But what we're doing is we're introducing new emotional context for a very difficult memory. And then when that trauma memory reconsolidates in the brain, it reconsolidates along with this new emotional information, which is that actually they were worth protecting. And somebody should have taken care of them and stepped in. And it's so powerful to do that kind of work with people. And it's so life-changing for people to now get the message in this deep emotional way that they're worthy and that they should have been protected and that they're worth loving. And once you unpack that for people, then they can go out into their adult lives and start interacting with the world as it is now in much healthier ways. And without this assumption that everyone's an asshole, everyone's a jerk, everyone's going to be abusive, nobody can be trusted. Because in fact, most people are actually pretty good people and can be trusted and are decent and caring and kind. But because that person had this childhood experience of being convinced that the world was an unsafe place, they've been interacting with everyone in their lives as if they couldn't be trusted, which makes it much more difficult to form loving, stable relationships. So we do both kinds of work in CBT. We can address things that are just brand new, one-off, this thing happened in adulthood, let's get this taken care of. Somebody fails to pass the bar exam and gets terribly depressed because they've always viewed themselves as, very, very capable. Okay, we can address that pretty quickly. Or someone who grew up really feeling very afraid of the world, feeling unworthy, we can address that too. They're just different techniques that we use.
That part sounds pretty similar to EMDR. And I have a question. What if the memory cannot be retrieved? Or another question, rather, do you start with something current or do you go to childhood? Where do you start in the second case when the beliefs are rooted, in
Sure. So in a case like that, I would actually start by ensuring that I knew that the person had some good emotional regulatory skills in the here and now, and that they had some distress tolerance, because this work is difficult, right? We're going to ask people to think about things that are hard and upsetting and anxiety provoking. And I want to make sure that the person isn't going to end up feeling so overwhelmed that they're going to go drink themselves into a blackout drunk, or that they're going to go engage in self-mutilatory behavior like cutting themselves or burning themselves. Because, by the way, those are perfectly rational things to do. They're not good things to do, but they're rational because they do reduce emotional pain. So people who are engaging in what we call non-suicidal self-injury are often doing so because they're feeling very, very emotionally overwhelmed. And NSSI actually helps with that. We know that. So it's perfectly rational behavior. But I always tell people, so I get why you're doing it. I'm not going to freak out. I'm not going to hospitalize you over it. But we have to teach you some other things that you can do to manage those overwhelming feelings. And you'll hear me come back to this again and again. Guess what? Deep diaphragmatic breathing is one of those skills that we're going to teach people. So mindfulness, deep diaphragmatic breathing, other kinds of healthy coping. We're going to teach people all those things to make sure that they can tolerate the work. And then we're going to go back and we're going to work on those childhood memories.
Is mindfulness, diaphragmatic breathing, and all of those things usually part of CBT, or is it specific to your work?
So they're absolutely part of CBT. This is what we would call third wave treatments, which take CBT and add components to it. So that includes schema therapy, right? What I was just talking about, where we're going back and we're doing some imaginal rescripting of some of those early memories when those really maladaptive, painful core schemas got started. Mindfulness. There are books that have been written about mindfulness-based cognitive behavioral therapy. It's been shown that it's a very, very useful part of treatment for people with obsessive compulsive disorder, for people with depression. There are really nice clinical trials showing that, in particular, it helps with relapse prevention. With my GI patients, I use a lot of mindfulness-based work because it's very, very helpful for chronic pain conditions. So what we're really doing is we're kind of strengthening the attention control muscle in the brain, and we're helping people shift attention away from sensations that are uncomfortable and unhelpful. in GI patients. So there are so many different components to what we do in various versions of CBT, but there are some basic things that go all the way through all of these treatments. Number one, we want to understand people's beliefs, and we want to understand where those beliefs came from and if those beliefs are accurate. And we want to help people learn how to identify their thoughts, how those thoughts give rise to feelings. We want to make sure people can label their feelings. Lots of people, when they start therapy, you'll ask them how they feel, and they say bad. I feel bad. Well, okay, there's 3 different kinds of bad. There's sad, there's scared, and there's angry. So which flavor of bad is this, right? So sometimes even just starting at that most basic level, helping people identify what their experiences were, what actually happened that day when you felt so bad. What were your thoughts? What were the actual flavors of feelings that gave rise to? What did you do about it? And then thinking back on it, what could we maybe do differently? How could we think about that differently? How could we cope with that differently that might lead to better outcomes? So that's a key piece. Another key piece is going to be exposure therapy. One of the main mantras for my practice with my patients is avoidance doesn't work. And that's true across the board. So if you're depressed about something that happened at work and you don't want to deal with it and you just decide to go sit on the couch and eat ice cream and binge watch Netflix, that's avoidance. You're avoiding the bad feelings. You're avoiding dealing with it. But it may feel good in the short term, but it never helps in the long term. Drinking, drug use, that's avoidance. Non-suicidal self-injury, that's avoidance. You're trying to avoid those bad feelings. Running away from the dog in the park and never actually petting a golden retriever, that's avoidance. Being afraid that somebody is going to reject or abandon you because you were rejected and abandoned as a child, and therefore ending that relationship, finding some reason to end the relationship before they have a chance to do that. Not very adaptive, because maybe that person was actually perfectly trustworthy and loving. That's avoidance. You're trying to avoid the pain of betrayal and abandonment. None of those things work well. People with OCD who are terrified that, if they touch a doorknob, they're going to get sick. And they'll go to all kinds of lengths to avoid touching doorknobs, and then they'll go wash their hands multiple times. That's actually avoidance. You're trying to avoid this thing that you're afraid of. It turns out you don't really need to be afraid of it. And if you confront it, you'll discover that you don't need to be afraid of it. So these are all through lines in cognitive therapy. And then teaching people skills for thinking about things differently, thinking about things more accurately, and coming up with more benign explanations for things that are more objectively accurate. Teaching people emotional regulatory strategies. So deep diaphragmatic breathing, mindfulness, all these different things that allow people to sort of manage distress more effectively so that they don't have to run away and avoid it, so they can confront it and learn new skills and not be so afraid anymore. These are all through lines in everything I do and in everything every good cognitive behavioral therapist does.
When you say we investigate the beliefs to see if they're accurate, can you say more about that? What do you mean? Are there accurate beliefs that give people discomfort? Or I'm a little confused, I guess.
Sure. So let me give you the classic example that I use with almost every patient. This is a great way to start thinking about it. I want you to imagine that you're walking down the street and you see someone an acquaintance, not a real close friend, but someone you know and are friendly with, walking down the street on the other side of the street in the opposite direction, right? So you're walking one way, they're walking on the other way, but you're on opposite sides of the street. And you wave to the person and they don't wave back. Now, that's the objective situation, right? That's what the camera at the ATM on the corner would have captured if anyone were to review that camera footage. But obviously, you could be having lots of different thoughts about that situation. For example, you could be thinking that person really doesn't like you and they're ignoring you on purpose because they don't want to deal with saying hello to you. So they're snubbing you in some way. That could either make you feel angry because the person's being a jerk. It could make you feel very sad because you feel like, oh, see, people don't really love me. People don't like me. I'm really kind of unlovable. It could make you feel very anxious. Oh my gosh, what did I do to offend that person? Did I do something wrong? And now I'm going to sit here and I'm going to ruminate about the last couple of times I saw that person and what did I do that offended them? Or you might think, that person didn't see me.
I think that's very unlikely. Most people usually go to catastrophizing, blowing it out of proportion type of route. We always think the problem is us, and we always interpret a neutral event.
Exactly right. But what if the person just didn't see you?
Exactly.
Now you're angry and sad and anxious for absolutely no reason, right?
But don't the current thoughts have connection to our history, to what happened to us in childhood? If you had a childhood where, rejection, abandonment was a major theme, you may interpret this situation through that lens.
Absolutely. And that's exactly what schema therapy would argue, is that we form beliefs in childhood that are the lenses through which we interpret things in the world, right? So yes, absolutely, our childhoods can set us up for things like that. And what is also interesting is that, of course, we'll see people have the very similar emotional reaction to lots of different situations. So the person who was angry at the person who didn't wave may also be really angry at the barber who gives them a bad haircut. And they may also be really angry at the roommate who leaves a couple of dirty dishes in the sink, right? Whereas the person who felt very sad or anxious when the person didn't wave will also be sad and anxious when they get a bad haircut, and will also be sad and anxious when the roommate leaves the sink, right?
So true. Yeah, it's always connected to our original wound or trauma. Like I know mine, and at this stage in my life, I recognize when something happens in the current day and I feel a certain way, neglected, abandoned. This is my theme, right? I immediately recognize it that this is not this neutral event has nothing to do with how I feel. This is all stuff that has been activated, and there's a lot of self-coaching and things like that. I mean, it still affects me, but I'm not mortified over it. I don't stew in it for days. I snap out of it very quickly, even though it's still painful.
So exactly. So see, what you're describing is someone who's self-reflected and done the work and has learned some compensatory skills, right? So you still have that vulnerability in you. It's not like that childhood magically disappears when we gain insight and learn all these new skills. That childhood is still there. But once you have the insight to recognize, oh, that's my core schema getting activated. That wasn't actually because the clerk at the store was, insulting me. That's not what was really happening, or whatever the proximal triggering event might be. If you can recognize, oh, I get it. I'm getting schema activated here, and I'm interpreting this neutral event, this objectively neutral event, in this really negative way, and then I'm feeling all kinds of terrible ways about it. I don't have to feel that way. That's not what this event is really about. That's just this old stuff getting stirred up, and I can put that back in its place. You're exactly right. You said it beautifully.
How can you help are there core schemas, like major schemas that you can maybe share with us so people can identify? Or how can someone recognize that this is a schema activation and pay attention to this and develop more awareness? Are there any practices or something practical you can share? Or is it case specific?
Yes, it's case specific, and there are general things out there. So a colleague of mine named Jeff Young has a wonderful, wonderful book on core schemas that is sort of a self-help approach. And he names a number of different, sort of types of overarching core schemas. So the defectiveness schema or the perfectionism schema, I have to do everything perfectly or I'm going to be a failure, things like that. So that's a wonderful place to start with. It's called Reinventing Your Life. But I would also tell you that when I work with individual patients, with these kinds of core schema issues from childhood, I will often coach the person to put a very specific name to the schema that really captures it for them. So I had one patient who called it my I suck schema.
I call mine abandonment boo-boo.
Right? There you go. Right? It's kind of a shorthand that you can use to remind you, oh yeah, that's this thing again. I have one too. My mother died of cancer when I was 14 after a long and horrible illness. And that's pretty emotionally scarring for a young person. In fact, there's some research that shows that losing a parent to death or illness in adolescence is particularly difficult, especially for girls, especially if it's your mother who dies. So my core schema is basically the world is a terrible and arbitrary place that can take away your loved ones at a moment's notice. That's a long name for it, but that basically sums it up. And so when something bad happens to me later in life, like my favorite uncle had a stroke at the point at which I was married and had a child, and I was very sad about it. And I started to get very, very anxious about my husband dying randomly or my child being killed or something, right? I started to be very fearful that something terrible was going to happen. And I was able to recognize, oh yeah, that's the world sucks and can pull the rug out from under your feet at any second arbitrarily schema getting activated. And I worked on it. And, I was able to get those feelings back under control and stop freaking out every time we fish, thinking that my husband was going to choke on a fish bone and die.
Yeah. And I'm sorry you lost your mom. I lost my mom when I was 13. So I can relate. And that's one of my schemas too. Now that you've mentioned, I have that one too. It's interesting. I've kept a journal, a diary since I was 13. And when I read all of those diaries, that gave me insight into my boo-boo, right? Into my pain point, into my schema. Otherwise it's kind of hard to see it. I guess some other people can see it, that you always are activated or triggered because of similar situations. But when someone is struggling, it takes some work to finally recognize, connect the dots and say, this is my schema. And even then it's pretty painful to deal with it. Now for me, it's a lot easier. But in the past, I could be swept by it and engulfed by it and for days and spin stories out of that schema and feel even more pain. But now I recognize it, and it took a long time to recognize that. I wish people can find a shortcut to recognizing their patterns, connecting those stories.
And that's exactly what a really good cognitive behavioral therapist is. Do,
okay,
right?
Good.
So one of the myths about cognitive behavioral therapy is that it ignores childhood. Of course, we don't ignore childhood. That's when a lot of really important learning happens. That's where we develop a lot of our beliefs about the world. It's where we learn a lot of our coping strategies is in childhood. Of course, we don't ignore childhood. That's ridiculous. We just don't think it's, because your mother was harsh when she toilet trained you or something, the way the Freudians believe, or because you have an unresolved Oedipal conflict or, right? That's all sort of nonsense, it turns out. But of course, we pay attention to childhood. And in good cognitive behavioral therapy, you are going to work on those core schemas, and the therapist is going to help guide someone to recognize those patterns. I have a patient in my practice right now who had a horribly alcoholic, abusive father who was really emotionally and physically abusive. And the coping strategy she learned in her family, she was one of many kids, and she was always the sort of good, quiet peacemaker kid, right? And she was in a situation at work in which she wasn't going to be paid as much for a job as she was contractually supposed to be paid. And she basically ended up saying, well, okay. And I was able to help her see, wait a second. No, that's not okay that they're not paying you as much as they said they were going to pay you. Why are you accepting that? And we were able to draw the dots, right? and connect the fact that, well, in your childhood, you learned to be very accommodating and appeasing because it was the only way to avoid getting hit. And it was the only way to avoid horrible drama and violence and rage in your family. So that was a coping strategy you learned that made sense when you were a kid. It may, in fact, have been a survival strategy as a kid, right? It wasn't a crazy strategy to have learned as a kid, but now you're applying it in adulthood in ways that are no longer serving you well. And she had this kind of real aha moment where she went, holy cow, I never would have thought of that connection. You're exactly right. It feels the exact same way. And so I was able to coach her to help her recognize that she shouldn't tolerate that from someone that she's working with. And that, of course, she should stand up for herself. That she has much more power now than she did as a child when she was being abused. That she has more knowledge, she has more skills, she has more resources. And she can stand up for herself now and make sure that people don't mistreat her in ways that she was not able to do as a child.
Can we talk about your paper about mindful breathing versus diaphragmatic breathing? I found that pretty interesting.
So what I was really interested in was exploring the difference in these two different strategies for getting people to slow their breathing down. Really, in the end, mindful breathing and deep diaphragmatic breathing get people to the same place in terms of their respirations per minute and heart rate variability and so on. But they feel very different in the instruction set. And although I think that mindfulness is an extraordinarily useful set of skills that can be deployed in people who, can be learned and deployed for people who aren't at all interested in the Indian or Chinese, the Buddhist or Hindu roots of any of these things. They don't want Buddhist prayer flags in their yoga studio. They don't want any of what I call the woo-woo parts, right? Which from a Western perspective is, of course, actually a complete misunderstanding of those Hindu and Buddhist traditions, but it's been layered on. Whereas diaphragmatic breathing is just a very, very, very concrete physical skill that people can learn to do. You don't have to believe anything. There's no sort of other cultural trappings around it. And so I was interested to see if there was a difference in the effectiveness of those two breathing retraining approaches, depending on people's kind of religiosity and their beliefs. And what we found was that indeed,
well, before you tell what you found, can you describe, I think, what mindful breathing is and what...
Sure, absolutely.
Because before I read your paper, I thought it's the same thing, probably. Do you know what I mean? It's not the same thing.
So in mindful breathing, what we get people to do is to just sort of close their eyes and slowly bring their awareness from the outside world into the breath and to pay attention to all the different sensations and components of the breath and to just observe it. And if their attention wanders, to bring their attention back to the breath. The breath is actually incredibly complicated. There's a lot going on. We don't think about it normally, but there's a lot of different things happening. The diaphragm is contracting, the rib cage and lungs are expanding, the collarbones and shoulder blades are shifting slightly. You can actually feel the air on the inhale in your nostrils and your sinuses and the back of your throat. And then it's much harder to detect on the exhale because it's been warmed and humidified. And all of those different things are happening. And for some people, if they have really good body awareness, they can actually feel their heart beating. And they can notice that their heart beats a little bit faster when they inhale and slows down when they exhale. So getting people to very quietly and attentively and mindfully focus on the complexity of that process and all of those different sensations, and then getting them to very intentionally slow the breathing down will actually lead people to engage in what is, in fact, deep diaphragmatic breathing, slow, deep diaphragmatic breathing. But you've done it by simply asking people to attend to the sensations in a non-judgmental and curious way. In deep diaphragmatic breathing, in contrast, we actually explicitly teach people how to slow and deepen their breath in order to do deep diaphragmatic breathing. The funny thing about this is that deep breathing is incredibly helpful, but the vast majority of people do not find it helpful. And that's because when you tell them to take a deep breath, they do it wrong. So most people, when they take a deep breath, do exactly what you do at the doctor's office, right? The doctor puts a stethoscope on you and says, take a deep breath, and you inflate the top part of your chest like that, and your chin comes up a little bit, and your shoulders go up, and your throat actually tightens, and then you release the air. That is actually a shallow thoracic breath, not a deep diaphragmatic breath. So since the vast majority of people do it wrong, I always have people, I say, go ahead, take a deep breath. And I watch them very carefully and I say, excellent, that was terrible. And they always laugh. And I say, no, the reason that was excellent is because it means I have a skill to teach you that's going to be a game changer for you. And for a lot of people, it really is. So then we teach people how to very intentionally inflate their lungs and exhale by using the diaphragm muscle. We start with an exhale, actually, where you tighten the diaphragm muscle almost as if you were like in a swimsuit commercial. And you really tighten that muscle and compress the belly, and you use that to expel the air as if you were blowing out, squeezing a balloon and blowing the air out. So we get people to exhale for a full 8 seconds. That's a long time. And then to just relax and let the air pour back in. And we're trying to get people down to a respiration rate of 4 breaths per minute, which is pretty slow. Yeah. Normal kind of walking around respiration is 16 to 20 breaths per minute. So we're really slowing it down. And by doing that, we're actually maximizing parasympathetic activation in the body. So we're slowing the heart, we're reducing blood pressure, we're easing muscle tension, we're suppressing adrenaline and cortisol, and most wonderfully for my GI patients, we're actually optimizing intestinal motility. So you can use deep diaphragmatic breathing, especially if you've got cramping, urgent diarrhea. Deep diaphragmatic breathing will actually sometimes stop that right in its tracks and will reduce the pain and the urgency. So that's a huge boon for people with diarrhea predominant IBS. It's also super helpful for people with panic disorder. When they're having these full-on sympathetic fear reactions, deep diaphragmatic breathing can slow that right down. It can just eliminate all of those sensations. It can be helpful for people with other kinds of anxiety disorders, OCD, PTSD, social anxiety. In all of those cases, we can use deep diaphragmatic breathing to help people tolerate the distress of the exposure therapy, right? So we want people to really lean in and do the things they've been avoiding and, kind of sit with the distress until it goes away. But deep diaphragmatic breathing is a way to make that much easier to tolerate. So we use it across the board.
Yeah. Do you do this during distress when you are feeling anxiety, or is it a wise idea to breathe like this throughout the day, which is kind of hard? I try to pay attention and practice. It feels like it's hard. So what's your recommendation?
So the recommendation is both and. So I typically give people an assignment to start practicing deep diaphragmatic breathing 3 times a day for 1 minute at a time. So I'm only asking for 3 minutes of their day. And I always tell them, you spend more time than that on Facebook or playing Candy Crush. You can give me 3 minutes. And each time to just take 4 super slow, deep breaths. And then when they get good at it and can reliably, for example, reduce their heart rate and feel that sense of relaxation, you can combine it with like a Fitbit or a fitness watch, or even one of the little cheap and expensive pulse oximeters we all got during COVID. You can get them for like $8.99 at CVS or Rite Aid. That'll give you a constant readout on your heart. Just do the deep diaphragmatic breathing until you can reliably reduce your heart rate, and then you're good at it. Now, once you have that skill, now you can bring it online when you're angry, when you're anxious, when you're upset about something. So, if someone cuts you off in traffic and you feel a volcanic surge of rage, take a couple of deep breaths. That'll calm things down. If, something startles you or you feel frightened or upset about something, take a few deep diaphragmatic breaths. That'll just notch everything down. It'll notch down all that arousal and that distress enough that you can think clearly about how to cope with it effectively. So it's both and. So I want people to practice it at times when they're not under duress so that they get good at it. And then it's available to them when they are distressed.
Is there anything, I think that's what I wanted to hear from this study particularly, but to conclude, can you say what you found, the results of the study?
Sure. So what we found in general was that deep diaphragmatic breathing worked well for everyone in terms of looking at some objective indices like heart rate variability at the end. Mindfulness worked better. Not better than deep diaphragmatic breathing, but it worked better for people who were more religious, who had that kind of spiritual outlook on life, than it did for people who self-identified as atheists or agnostics. For those folks, the kind of very skill-based, rational, nope, here's how we're going to teach you this skill, as opposed to, I want you to just pay attention to the breath in a non-judgmental way. It worked better for them. Now, I will say that when I work with folks, sometimes with panic disorder or with chronic illnesses, GI disorder, chronic pain conditions, for people who feel like their body has become the enemy and their body doesn't work well for them and they don't trust it, some of those folks actually have a really hard time learning deep diaphragmatic breathing. And for those folks, the mindful breathing can sometimes be a much more effective approach, because it doesn't require controlling the body, right? It's just paying attention to what's happening in this sort of compassionate and non-judgmental and curious way. So for folks where you feel like your body has become your enemy, sometimes the mindful breathing is a better way to teach them the skill.
Interesting. If I ask you to share a tool for the listener, is there a tool that you can share, a practical tool, CBT tool that they can apply today, or it has to be case specific?
Well, I absolutely believe that everybody can benefit from learning deep diaphragmatic breathing. You'll see I keep beating that drum. But the other thing that I want to remind people of is that fundamentally in life, avoidance doesn't work. It's tempting because it relieves distress in the moment, but it almost always makes things worse in the long term. So whether you're talking about getting your taxes done or going and talking to your boss about that raise you think you're overdue for, or whatever it is, cleaning up your room, getting the laundry done, cleaning the basement, whatever it is, just do it. Avoidance doesn't work.
And Melissa, you have a book coming up in the fall. Can you tell us in a few words what the book is called and what it's about?
So the book is actually, the one that's coming out in the fall, is actually a treatment manual for professionals to learn how to do cognitive behavioral therapy, specifically for individuals with inflammatory bowel diseases like Crohn's disease and ulcerative colitis. I do have 2 other books, of course, which are already out, which are written for people in the public, for lay audiences. One is written for people with irritable bowel syndrome called Reclaim Your Life from IBS. And the other is written for people with inflammatory bowel diseases. It's called Coping with Crohn's and Colitis. And both of those books take a basic cognitive behavioral therapy kind of paradigm and apply it in a self-help format specifically to individuals struggling with those particular GI conditions. And I'm very proud of the fact that I tested both of those books in randomized controlled trials as standalone treatments prior to publishing the books themselves. So I know that those treatments are helpful. And to this day, they are the only 2 psychological self-help books that were tested in randomized controlled trials prior to publication.
Excellent. Well, congratulations. It was truly an honor and pleasure speaking with you. I expanded my mind, and definitely, yes, for diaphragmatic breathing, we all need to practice that more and more. Thank you so much for your time and for your knowledge and your willingness to be to share today. I appreciate it.
It's been a real pleasure. Thank you for the opportunity to get the word out. I've enjoyed it.
Thanks.